Hello, and thank you for joining today's webcast, Our Call to Action, Upgrade Patient Monitoring in General Care Units to Help Save Lives, presented by Professor Bernd Saugel. My name is Jonah Atterbury. I'm a physician and medical director of monitoring solutions at GE Healthcare, and I'll be facilitating today's webinar. Before we begin, we want to cover a few housekeeping items. At the bottom of your screen are multiple application widgets which you can use. I'll briefly cover the most important ones. During today's webcast, you can submit questions through the Q&A widget. We'll try to answer as many questions as possible at the end of today's presentation. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen. And for the best viewing experience, we recommend using a wired internet connection and closing any programs running in the background. Lastly, this webinar recording is the exclusive property of GE Healthcare. No part of the following content may be copied or reproduced without prior written consent from GE Healthcare. I'd now like to introduce today's speaker, Professor Bernd Saugel. Dr. Saugel is Professor and Vice Chair of Department of Anesthesiology at the Center of Anesthesiology and Intensive Care Medicine in the University Medical Center, Hamburg-Eppendorf in Hamburg, Germany. He's board certified in anesthesiology, intensive care medicine, and internal medicine. His research interests include optimizing hemodynamics in patients undergoing high-risk surgeries and critically ill patients. And he currently serves as the editor of the British Journal of Anesthesia, where he has published many peer-reviewed articles. With that, I'll turn it over to Dr. Saugel.
Thank you very much for the introduction. Hello, everyone. I'm very happy to be here today and to speak to you about our call to action and why we should upgrade patient monitoring in general care wards to save lives of our patients. These are my conflicts of interest. So in this talk, I will explain to you why I think that advances in patient monitoring will lead to substantial changes in how we treat our patients. And this is not only true for patients who are treated in a hospital, but it's also true for patients who we take care of in ambulatory settings and even patients who may be outside the hospital and can still be followed up by us, for example, after surgery when patients are already dismissed and going home. But before I share with you my visions and my expectations for the next 10 or 20 or 30 years, we of course need to start in current times, and we need to discuss how we monitor our patients today. And if we look at this, if we look at patient monitoring in 2024, we need to say that if we speak about vital signs, hemodynamic monitoring, cardiorespiratory monitoring, most of the sensors we use today are invasive. The monitoring systems we use in a hospital are almost never wireless. They are almost never integrated, meaning that the different monitoring systems can talk to each other and can talk to the electronic health records. And a corollary of that is that continuous monitoring today is basically only performed in patients who are treated in intensive care units or in operating rooms. If we think about how we monitor our patients today on a general care ward, we need to say that most of this monitoring are manual intermittent measurements. Usually those are spot checks by nurses every 4 to 8 hours or once a shift. And if we speak about ambulatory patients outside the hospital, there is basically no monitoring today outside the hospital. A reason why we monitor patients like this, besides the fact that most of the monitoring systems we use are invasive, may be how we can conceptualize our care and how we think about different places patients can be treated within a hospital. And I think during the last decades, we established a thinking of, okay, intensive care units and operating rooms are the dangerous places where patients are critically ill, patients where there's a high mortality rate, and general care wards are the safe spaces, the safe environments within a hospital where the more or less healthy patients are and where mortality rates are low. And this is very, very deeply rooted in our thinking and in our concepts of patient care. And this is very nicely reflected by an example that I always share. And if we think about how we communicate with patients and families in the perioperative experience, you will probably know that when a patient is having surgery, here we are in the operating room, at the end of surgery, even when the patient is still under general anesthesia, we will call the families and say, surgery went well and everything is fine. Your relative is still in the operating room, but you can visit this afternoon on a general ward. And of course, this call is reassuring, and thousands of patient families receive relieving calls like this every day. But if we would be brutally honest, and of course we don't want to be that honest, but if we would be, we would call and we would say, okay, surgery went well, this is an important step, and everything is fine so far, but the most dangerous time is still ahead. The postoperative period, the first month after surgery, poses a much higher risk for patients than surgery itself. And of course, we do not do that, but that call would much better reflect the risk of patients who have surgery in hospitals throughout the world. And I will give you a few numbers and put a few numbers around this. So if we think about intraoperative mortality, this is mortality in the operating room. This today is very, very low. In fact, it is so low that it is hard to measure in clinical studies, and it decreased by a factor of about 100 during the last century. Just in contrast, postoperative mortality is not low. It's about 100 times more common than intraoperative mortality. If you put that into perspective, or if you put that differently, you could also say that if the month after surgery would be considered a disease, it would be the third leading cause of death globally. And this is very interesting and reflected by numerous studies in the last couple of years, and I will just give you a few examples. This, for example, is a 7-day cohort study performed in almost 500 hospitals across Europe, and the authors looked at in-hospital mortality after non-cardiac surgery. And altogether, in the large patient cohort, in-hospital mortality after non-cardiac surgery was around 4%. This is a European study, and you can now look at the list and look at the country you're located in and can see the mortality rates in your respective country. For example, in Germany, the in-hospital mortality rate was 2.5%, which is not low as a percentage number, of course, but if you think how many patients have surgery each year, it's an enormous absolute number of patients we lose just a couple of days after surgery. And this is not a European problem. The same is true in the United States. These are data from the United States. Again, the postoperative mortality rate within a month after surgery is around about 2%. And so we can say that in Europe and in the United States, about 2% of major non-cardiac surgery patients die within the first months after surgery. An important and reasonable question then, of course, is when do patients die after surgery? Because if we speak about monitoring on normal wards, we want to know when our patients are at the highest risk. And there is an interesting secondary analysis of a large study of more than 40,000 patients just addressing this question. Again, in this cohort, about 2% of patients died within the 30 months after surgery. So this is surprisingly consistent across different cohorts. And if you now look at this chart, you can see on the x-axis the postoperative days. So there are 30 days after surgery. On the x-axis, there is the first month after surgery. And then the y-axis, there is a cumulative percentage of patients who died within that time frame. And now you could expect, for example, that most of the patients die in the first 1 or 2 or 3 days after surgery. This may be a time when patients are still in the intensive care unit or in higher acuity care settings. But you could also assume that patients die later after they develop complications, for example, infectious complications or sepsis, and that this becomes a problem only a couple of days after surgery. But the truth is that this curve is relatively linear, meaning that during the first month after surgery, we lose patients basically every day. And this is not necessarily a problem of the first postoperative days or something that only develops later. And it's a problem that is simply there during the first month, and of course requires that we identify patients at risk and that we monitor patients at risk during those dangerous times. Where do those patients die? So do they die in the operating room, in the intensive care unit, or on normal wards? And again, the study gives us perhaps surprising and frightening numbers. As I already told you, mortality in the operating room today is very, very low. So less than 1% of the patients who died within the first month after surgery died in the operating room. In other data sets, this proportion of patients is even much, much lower. Again, I told you that during surgery, mortality rates are very low, very, very low, often too low to measure. But the important number is that 30% of patients who died within the first months died during the index hospital stay, meaning that is the hospital stay that began with surgery, and before being dismissed and sent home, patients die in the hospital, our direct supervision. And then 30% of patients who die within the first months die after initial hospital discharge, often at home or in different other hospitals, or they are readmitted to the same hospital. In the European cohort study that I showed you a few minutes ago, that looked at in-hospital mortality after major non-cardiac surgery, a very, very interesting finding was that more than 70% of patients who died in hospital never were treated in an intensive care unit after surgery, meaning that those patients most often died on normal wards. And this is not only true for patients who have surgery, it's also true for patients who are admitted to hospitals because of medical non-surgical problems. And if you then look at in-hospital adverse events and where those events take place, you can see that about a quarter of the severe complications occur on general care wards. So the patient's room that is often conceived as a safe place is not at all safe. It's a place where many, many complications occur. So our concept of the intensive care unit and the operating room as the dangerous places with high mortality rates, critically ill patients, is not completely true, because also the general care ward is a place where patients unfortunately experience complications, where patients die, and we today, especially because patients are getting older and sicker, by no means can assume that the general ward is a place where healthy patients are and few complications happen and mortality rates are low. What does all of this has to do with patient monitoring on general care wards? Well, complications that then eventually can lead to death on general care wards cause alterations in vital signs, and we should monitor those vital signs in a way that we can pick those alterations up early in the course of the deterioration and can implement actionable interventions to avoid further deterioration. If we look at the complications that can cause to more dramatic clinical situations like cardiac arrest or even death, if we again look at post-surgical patients, The complications are well established. It's major bleeding, myocardial injury and infarction, sepsis, acute kidney injury, stroke, and congestive heart failure. And if we look at the complications that are most strongly associated with death, have the highest attributable fraction of risk, we can see that the three main complications are major bleeding, myocardial injury, and sepsis. And these complications all result in alterations of vital signs. They increase respiratory rate, they may decrease peripheral oxygen saturation, increase heart rate, alter the heart rhythm, and may lead to hypotension. So they make also induce changes in blood pressure. Again, this is not only true for surgical patients, it's also true for patients who are treated in hospital for any other reason. If we here look at a figure showing or analyzing patients who had cardiac arrest on a general ward, and this is a case control study comparing those patients who had a cardiac arrest to patients who did not have a cardiac arrest, and we look at a modified early warning score on the y-axis, you will see that there is a difference between patients who later do or do not develop cardiac arrest. So patients who develop cardiac arrest on a ward have alterations in vital signs that then result in a higher modified early warning score hours before the event. And if you look at the x-axis, you can see that those changes can often occur up to 48 hours, 2 days before the event. And if we would monitor those vital signs and calculate regularly calculate early warning scores, we may much earlier than we often do it today recognize that the patient starts deteriorating and may be at risk for developing more serious complications. This is a very similar analysis, almost 8,000 patients, adults who then unfortunately developed in-hospital cardiac arrest. And if we look at the number of pre-arrest abnormal vital signs and their relation to the mortality rate, you can see that the higher the number of abnormal vital signs, the higher the risk of dying. And this is only also true within one vital sign. The more abnormal, the more pathologic a vital sign is, the higher the risk that the cardiac arrest will finally result in death. The big problem is the problem that we need to address, and the problem that we now should focus on is that we, with our current monitoring, we are very bad in detecting vital sign alterations on general care wards. The big problem is that we very much focus on how we rescue patients, and we not so much focus on how we monitor patients and how we how good we are in identifying alterations in vital signs. And this is very nicely reflected by the failure to rescue concept that you probably heard of, that was established many years ago. And the basic assumption of this concept is that when you develop, that everybody or in every hospital, patients develop complications on general care wards, and you can then differentiate between good and bad hospitals, defined regarding how high is mortality, based on the fact how good a hospital is able to respond to those complications and how high the failure to rescue rate is. Meaning that good hospitals can implement better treatment strategies and better rescue the patients when a patient has complications. And I think that we need to completely revise this concept, and we need to focus much more on not how we rescue the patient when there's already a code blue alarm or already a cardiac arrest, for example, but we really need to focus on how good are we in early identifying and detecting complications by alterations in vital sign. And I would say the goal would not only be to minimize the failure to rescue rate, but we need to improve our failure to monitor. So we need to avoid that we don't monitor patients or monitor patients only intermittently and fail to identify the complications early. Again, the big problem is that current monitoring that on general care or normal wards consists of spot checks by nurses every 4 to 8 hours. And I will now show you a couple of problems that are coming with this intermittent spot checks. And I will just focus on 3 important vital signs, cardiorespiratory variables. The first is respiratory rate, then peripheral oxygen saturation, and blood pressure. If we speak about respiratory rate, we can look at this retrospective observational studies of patients who were treated on general care wards. And those were patients who had an adverse event. And this study looked at all vital signs that were collected and documented in the 48 hours before the adverse event, just to see how often those vital signs were checked, whether those vital signs were abnormal or normal, and whether they could have predicted the adverse event. An interesting fact about respiratory rate here is that respiratory rate was documented in only about 1/3 of the assessment by nursing staff during their spot checks. So respiratory rate is very, very rarely documented and very, very rarely measured. If respiratory rate is measured, it is very, very often measured incorrectly, and this is kind of provocatively reflected in this study. More than 35,000 hospitalizations, and if you look at the respiratory rates of the patients, they are surprisingly clustered around respiratory rates of 18 or 20, which is not physiological, of course, because everybody has different respiratory rates, often maybe 17, 21 or whatever. But in clinical practice, you usually observe the patient for a couple of seconds and then multiply that respiratory rate to result in a respiratory rate per minute, and that results in documented respiratory rates that are usually multiples of 2. And this is not the only study showing this. This is a very similar approach. So if you look at respiratory rates documented in patient medical records, those often are 16, 18, or 20. Again, multiples of 2 or 4, just reflecting that the way we measure respiratory rate today are insufficient. So we look at the patient for a couple of seconds and then multiply the respiratory rate to reflect respiratory breath per minute. If you challenge this way of measuring respiratory rate with an automated point of care measurement method, you can see that there is a substantial difference between manual measurement of respiratory rate and automatic measurement of respiratory rate. And very, very often we document respiratory rates that are incorrectly. You may now, of course, ask, is that important? Is measuring respiratory rate correctly something that we should focus on? And I can tell you, yes, it is. This is a list of vital signs and other variables and parameters and their observation, their association or importance for detecting clinical deterioration. And you will see in this study, and this is consistent across other studies too, that respiratory rate is a very, very powerful predictor of clinical deterioration. And therefore, patients do deserve that we measure respiratory rate frequently and, of course, correctly. Because higher respiratory rates can be very sensitive in detecting clinical deterioration, just as you can see in the list, heart rate, blood pressure, and other variables. So respiratory rate is important. Of course, peripheral oxygen saturation is important too, because it does not only reflect cardiocirculatory problems, but also, of course, pulmonary and respiratory problems. And again, we check SpO2, so peripheral oxygen saturation, like every 4 to 8 hours in our patients on general care wards. And in this prospective observational study, the authors measured SpO2 at 1 minute intervals in a blinded way. So clinicians were not aware of the blinded measurement. And this was done in more than 800 patients who had non-cardiac surgery. It's very shocking that about 1/5 of patients had more than 10 minutes with an SpO2 of less than 90%. And it's even more shocking that our routine 1 to 6 hour our spot checks at 4 to 6 hours intervals would have missed 90% of the hypoxemic events. And if you looked at the charts, only 5% of the patients had even a single SpO2 of less than 90% documented in the electronic health record. So hypoxemia, SpO2 below 90% is common, but it is usually missed by our intermittent spot checks. Now let's speak about blood pressure a little bit. Blood pressure is a very special vital sign or biosignal. First of all, it's very complex to measure. Even in the operating room, we struggle how to measure blood pressure correctly. In high-risk patients, we will use an intraarterial catheter to measure blood pressure directly. In most of the patients having surgery, we will use an intermittent oscillometric measurement system with an upper arm cuff. And in patients who are treated in low acuity care settings, like in general care wards, measuring blood pressure correctly and continuously or high frequently is a big challenge. Again, blood pressure is usually then only measured every 4 to 6 hours during those spot checks. This is then usually done automatically with an oscillometric upper arm cuff. But yeah, it's an intermittent measurement, and it's by no means high frequently measured or even continuously measured. We looked at blood pressure in low-risk patients who were recovering from non-cardiac surgery in our post-anesthesia care unit. So the post-anesthesia care unit is the place where the patients stay for the first 1 or maximum 2 hours after surgery. And we measure blood pressure in a blinded way and a non-invasive way in the post-anesthesia care unit. And we found that hypotension in that setting is relatively rare. Very few patients had mean arterial pressures below 65, and also blood pressures below 70 were relatively rare. And therefore, I do not think that the post-anesthesia care unit is an area we especially need to focus on, because it is directly our patients are just emerged from general anesthesia, may have a little bit of pain, may still be hemodynamically optimized by intraoperative hemodynamic management, and are still in a very well monitored. There are clinicians at the bedside, and then after 1 or 2 hours in the post-anesthesia care unit, we send our patients to the general ward. And there things are different. On general care wards, there are a lot of different potential causes why patients can develop postoperative hypotension after surgery. A big problem is that we start the antihypertensive drugs again that usually are paused for the day of surgery, at least some of them, and often not really considering the blood pressure patients actually have after surgery. We just start the chronic antihypertensive drugs patients are on before surgery. Patients usually do not drink and eat as much after surgery, so there may be intravascular hypovolemia, there may be a complication of bleeding, they may develop postoperative systemic inflammation, cardiac arrhythmias. So many potential causes for developing hypotension. And we now looked at 250 patients who were treated on general wards after non-cardiac surgery. And what we did, we measured blood pressure before and after surgery with an automated system at 30-minute intervals. This still is not a continuous measurement, but at least is substantially more often than our routine spot checks at 4 to 6 hour intervals. And this may be a little bit complicated, but it's important. We defined new onset postoperative hypotension. So this is hypotension that the patient is not used to, by saying this is a mean arterial pressure below 65, when this blood pressure also is lower than the blood pressure the patient had before surgery. Because if you have low blood pressures before surgery, it's very unlikely that low blood pressures after surgery reflect a clinical problem. But if you are used to high blood pressures, normal blood pressures before surgery, and then you develop hypotension after surgery, this may indicate that there may be a problem like bleeding or sepsis. So of those patients, 40% had postoperative hypotension for a median duration of 90 minutes. And in half of those patients, and 18% of all patients, this was clinically important new onset hypotension that the patient was not used to, so hypotension or blood pressures that were substantially lower than the regular blood pressure of the patients. So hypotension is a problem on normal wards, and this has been suggested a couple of years ago in a sub-study of a big trial, the POISE-2 trial. And here hypotension was defined as a systolic blood pressure of less than 90 millimeters of mercury that required treatment. And you will see that about 1/3 of the patients had low blood pressures during surgery. On the remaining day of surgery, about 1/3 had hypotension, but there were almost 8% of patients who had hypotension on the postoperative days 1 to 4. And this hypotension was important. If you look at the odds ratio, so the risk for myocardial injury and death on the y-axis, you can here see an illustration. This is the risk when your blood pressure is low during surgery for 10 or for 30 minutes. And this is the risk. This is about 3 times the risk of patients who do not have hypotension if you develop hypotension on postoperative days 1 to 4. So postoperative hypotension does not only seem to be common, there is also associated with a higher risk of myocardial infarction and death. This was confirmed by another study, more than 1,700 non-cardiac surgery patients who were treated in a high dependency unit. Again, postoperative hypotension was common, about 10 hours with a mean arterial pressure of less than 60 millimeters of mercury. And this hypotension, again, was associated with risk for developing myocardial injury. The problem again is that we miss hypotension with our current approach to monitoring, and this will be one of the last studies I show you, and then I will move on to innovative concepts, how we can tackle the problem of missing abnormal vital signs. Here you can see, for example, that having a mean arterial pressure of less than 65 for about half an hour, around about 15% of the patients, and this hypotensive episodes were detected in only 2 of 10 patients with our routine vital sign assessments. So 2% of patients die within a month after surgery. 2/3 of those patients die during the initial hospital stay under our direct supervision. This is also true for death in medical non-surgical patients. Are caused by complications. Those complications induce alterations in vital signs, and our current approach to vital sign monitoring with spot checks misses most of the vital sign alterations. So what we experience basically every day is that with our intermittent spot checks, we identify clinical deterioration very, very early, often only after there is cardiac arrest or other very, very serious complications. And to illustrate this, I will show you this figure that represents a realistic scenario of what happens in many, many hospitals throughout the world, unfortunately, every day. So imagine a patient who is well at 4 o'clock in the morning, but at 4:40, he or she develops a respiratory problem, for example, gets hypoxemic, does not have enough oxygen in his blood, and that only a couple of hours later during the first round of the nurses in the morning, for example, at 6 o'clock. And this is typically when the code blue alarm or the emergency rapid response team pager or telephone rings. And then we run to the patient and try to rescue him or her. And we are very, very late in that process of clinical deterioration. Imagine if this patient would have portable bedside monitoring of vital signs, wearable sensors, sensors attached to the body, sensors like finger rings or watches. If that patient would have such a wearable wireless monitoring system, we would instantly recognize clinical deterioration. We could instantly give an alarm to the nursing team on the ward or to a physician, and we could just a couple of minutes later be at the bedside, for example, do a simple intervention like give an oxygen, and we may prevent major, much more severe complications or even cardiac arrest or death. Of course, if you kind of depict it in a illustration like this. And a reasonable question, of course, is continuous ward monitoring possible today in our clinical hospital settings? And I would say, yes, we are getting there. There are now non-invasive sensors that indeed are wireless, wearable, integrated monitoring systems that allow continuous monitoring outside the ICU or the operating room. We call that ward monitoring, and becomes available for research purposes, also for clinical implementations. But there are still many obstacles and hurdles that we need to overcome. And without getting into the details, you will see that there are now numerous different monitoring systems available. Many of them are adhesive patches. And I show you that slide not to get or to discuss any single monitoring solution, but I just want to show you, you can see the different vital signs here. So respiratory rate, heart rate, ECG, SpO2 monitoring, and you will see that measuring blood pressure is a big challenge. So there are very few systems that are actually able to measure blood pressure correctly and high frequently or even continuously in patients on the normal ward. And this is definitely something that industry and researchers need to put to also provide systems that are able to measure blood pressure. Although it may be enough to monitor respiratory rates, heart rates, and SpO2, if you would just measure those three hemodynamic or cardiorespiratory variables, you would probably identify a lot of patients deteriorating on wards, even if you're not able to measure blood pressure continuously. To measure blood pressure continuously, there are a couple of systems: volume clamp, vascular loading methods, pulse decomposition methods, applanation tonometry, or pulse wave transit time. And just to give you one example, because this is something that we are working on in our group, we try to miniaturize those sensors and kind of give them a variable form factor, for example, like a watch or here a finger ring. And this is an area of research where a lot of there's a lot of things going on in this area, and the big problem, of course, is to provide a system that is intuitively to use, that does not disturb patients' sleep or mobilization, and this is a very important thing, of course, measures correctly what it's supposed to measure. And therefore, our call for action here is that, of course, we first need to validate those measurement systems. We need to measure. We need to assess their agreement with established methods. We need to get some clinical data on how good do those methods measure vital signs. We only then can use those measurement methods to measure vital signs in interventional outcome studies, where we actually show that continuous monitoring improves patient-centered. And then we can try to implement those systems in clinical practice. And this is probably something that we will discuss after the presentations, because depending on the system you are dealing with or you're working in, there are then many hurdles how to implement systems like that in current clinical pathways. There are there are some data now that show that implementing those systems in routine clinical care can improve outcomes and also can reduce the workload for nurses. So here you can see a very small kind of pilot study, only 40 patients, but it's still important to show because it makes an important point. Nurses are sometimes afraid that continuous monitoring on normal wards may increase their workload because there are more alarms and more things they need to react to. But I would argue that if a continuous monitoring system is attached, this should decrease the workload of nurses because, first of all, they can focus on those patients who actually require attention and do not need to waste time to spot check patients who are completely stable. And you can see that in this study, the duration of vital sign monitoring per patient per 24 hours, so the time that nurses and clinicians need to invest in monitoring was lower in patients who were assigned to continuous monitoring, showing that doing those rounds, doing those spot checks costs a lot of time, and that continuous automated monitoring may even save you time. There are the first studies showing that implementing those systems can actually improve outcomes. Very often those studies are not randomized trial, but so-called before and after studies. So you're looking at a before period where there was intermittent, non-continuous monitoring, then you implement the monitoring system, and then you have an after period in which patients have continuous automated monitoring, and then you compare the outcomes of those of the patients during those two periods. There are inherent methodological limitations of an approach like this because there are a lot of things in patient pathways and clinical care that can change over time, but nevertheless, those studies are important. And for example, in this before and after study, the rate of admissions to an intensive care unit and the rate of rapid response team calls clinically was reduced with continuous monitoring, and this was to a clinically important and also statistically significant degree. Another single center, in this case, propensity analysis in patients who were monitored in surgical wards after surgery in the United States, also suggests that continuous monitoring can improve patient-centered outcomes. And this also included in-hospital mortality, admission to an ICU, or myocardial infarction. We need much more trials on this. We need much more robust data showing that and proving that continuous monitoring can actually improve patient-centered outcomes. But I think that these first studies showing that those continuous monitoring systems can decrease nurse workload and actually improve patient-centered outcomes are promising and should prompt us to design much larger, more robust, and more definite trials. So what do we expect in the next 10, 20, 25 years? I would say we all together need to be smart when we speak about future developments, and smart means we need to be, we need to figure out what an optimal patient selection is. So do we want to monitor every single patient in a hospital? Do we first want to focus on patients who are at particular risk, like patients after surgery or patients treated in cardiology departments or whatever? I think the goal should be that in the year 2025 or 2050 or whatever, every single patient in a hospital is continuously monitored, and that we do not really remember that we once looked at our patients only every 8 hours. But yeah, to implement those systems, we probably need to select a specific group of patients first. Then, of course, there's a lot of things to do regarding the monitoring. This is mainly on the task for companies and industry. There is so much going on in with regards to sensor technology. Sensors are getting smaller. Sensors are getting more easily to handle. They, of course, should not disturb patients. They should not prevent patients from walking around doing physical therapy and stuff like this. So monitoring is something, there's a lot of things going on in this area. We need to think about alarms. So we need to be very smart with the alarms. Of course, those alarms need to be contextualized and individualized. It's not, for example, a heart rate of more than 100 always triggers an alarm. It's a difference whether a patient is lying in bed or is having physical therapy. And for example, for patients with chronic respiratory lung disease, a saturation of 92 may be perfectly fine, versus a saturation of 92 may be a bad sign for a young and healthy patient. This is what I mean when I say that alarms need to be contextualized and individualized for each individual patient. Then we need to figure out what the best response to those alarms is. Who is going to take care of the patients during clinical deterioration? Is it the nurse on the wards, the physician? Should there be always a rapid response team call? What triggers a rapid response team call? And things like that. So this is something that we as clinicians need to figure out what the best response to those alarms is. And then, of course, we need to figure out what the best therapeutic interventions are in patients on general care wards, because we cannot use the same therapeutic strategies that we use in patients who are treated in intensive care unit settings. Yeah, at the end of the day, we will hopefully then work in environments where every single patient in a hospital is continuously monitored, where all the data that come from real-time inpatient monitoring go to some probably artificial intelligence-driven algorithm that selects what is an artifact, what is an actionable alarm, what is an important alarm. Is that vital sign alteration important for the individual patient? And then we will monitor all of the patients and can identify patients who are at risk for developing severe complications and send a clinician to the bedside right away. And if we would do that, we could definitely save our patients' lives, at least a few of them. And then we would definitely be able to improve patient outcomes. And with this, I come to an end. I thank you for your attention. I just read in the chat that my webcam froze. I will just restart it. And I thank you for the attention. And I'm very much looking forward to the discussion. Thank you very much.
Thank you, Dr. Saugel, for showing all your expertise and insights. Now is the time of our webcast where we will address some questions submitted during the presentation. At this time, we are only able to address questions that were submitted in English. Additionally, please note questions or responses may not be relevant for all countries. So there was several questions in the Q&A as you were speaking, and I'm going to try to do my best to try to summarize one of the questions here, which really relates to nursing shortage. Nursing shortage is a huge issue here in the US. It seems to be a global issue. How do you see this sort of interacting with what we see as maybe a lack of training in some nurses, maybe a rush of nurses out of training into the bedside? I know you spoke a little bit about nursing concerns about alarm burden, how that hasn't played out, but how do you see these two things interacting?
Yeah, well, this is a shortage of staff is one of the major healthcare problems, I guess. Basically, I think that we need to understand that continuous automated monitoring systems have the goal to decrease the workload. Of course, we will in the beginning, you will need to invest some time in training, for example. We need to know how those systems work. We need to implement those systems. But then they are supposed to decrease the workload. And I especially like to focus on the fact that if you are working on a ward with, I don't know, 30 people, 30 patients, at the moment you will spot check those patients every 4 to 8 hours, whether they are just had surgery yesterday or a week ago, or whether they are in a critical condition or not. So we check a lot of vital signs in patients who are completely stable over days, but we all check vital signs only every 4 to 8 hours in patients who just develop a complications. And in those patients, we should monitor those all the time. And those continuous automated monitoring systems will kind of help us to automatically ignore those patients who are completely stable and focus on those, let's say, 3 out of the 30 patients who require our attention now and today. And this will probably help to relocate resources to those patients who actually need it, and it will decrease the kind of the workload that is also not very satisfying, because just checking something because it needs to be checked is not very satisfying and not very meaningful. And therefore, I hope that continuous monitoring will help increase satisfaction by clinicians and also decrease the workload, then make it a more attractive again, and help resolve the staff shortage problems.
It's an interesting insight. I've not thought about it in that way, in terms of we are now taking clinicians, the bedside nurses, physicians, etc., and not making them do repetitive, maybe boring tasks, but actually directing their care towards the sick patients, where it might be more fulfilling to be taking care of those patients. So
yeah,
it's an interesting concept. There are a couple of questions also in the chat here about how to institute this into hospital systems. So there's a question here about really who are the champions you see for continuous monitoring within the hospital? Who are the people that need to be convinced around this? Certainly we see that there is a need for it, and there are improved outcomes, but who are the people who you feel need to understand this, that might not understand this need quite yet?
Yeah, this is a very, very interesting and very practical but complex question, because it's you basically need everyone. You need to have the nurses on board who actually want to do that. And from the studies and trials we are running in our institution, I learned that this usually it's not a big task to convince nurses that this kind of monitoring is important. It's then you need to have the clinicians on board, meaning the physicians, surgeons, internal medicine, anesthesiology, and this is something that usually, it's also usually easy to convince colleagues that this kind of monitoring could be important. And then there are many other stakeholders that you need to get on board. And one very important thing is you need to have all the IT folks on board. Implementing those systems into complex hospital IT infrastructure is a big challenge. So for our studies, that from time to time takes months to implement a system, simply because there are so many data protection rules and stuff like this. So you need to have those people on board, and then of course you need to have hospital administration and finances on board. And this is something that is challenging at the moment, because we do not have clear, convincing data that you improve patient-centered outcomes, and by this you can reduce hospital or costs per patient or something like that. It makes sense that avoiding severe complications, picking up less severe complications early makes sense. At least it makes sense if you're are patient-centered and want to improve patient care. And if you think about it in a way, how do I or my relatives, how should they be monitored when they are in the hospital? But there is no hard, let's call it business case at the moment, showing that you actually save a lot of money with this. I think we will get there if we have more robust trials showing that there is a reduction in complications and stuff like this. Then there will be cost effectiveness analysis, but those data are not there yet. But yeah, hospital administration and finance, of course, is also something that you need to consider when you want to implement this.
That cost piece is something that's come up in the questions as well. Is there a way that you see this cost reduces? Because this is not a free system. These are systems, especially with new technologies, that oftentimes require a large purchase up front. So how do we, as device manufacturers, as developers of technology for this, make this affordable for patients? Or is it something that will have a big expense, and we just need to recognize that expense, the payoff for that is patient safety?
Well, first of all, as a physician, I focus on patient safety, of course, and of course the price tag on continuous monitoring, and it's will not come as a surprise that hospital systems, clinicians prefer the systems that are affordable, that are implementable, that is clear, that is a no-brainer. I'm as a device manufacturer, the first important thing you should focus on is that the systems that you provide accurately measure what they are supposed to measure. So I think measurement performance and clinical applicability and feasibility is key. Of course, it will come with the cost. You may counterbalance this with the cost for personnel that is perhaps can be redefine what they are doing during their shifts. Of course, avoiding severe complications will at the end save costs, but all of this takes a lot of small incremental steps, I would say, because it may even result in a complete restructuring of hospitals, of the hospital infrastructure that we have today. So probably in many years, and you can see that, for example, in the United States, where my impression is that the hospital landscape already changed during the last decades, that you have more and more monitoring beds and less kind of normal beds. And probably we will, there's a clear trend towards ambulatory care, ambulatory surgery, and hospitals will probably become smaller in terms of number of beds, but the proportion between intensive care unit beds and normal beds will dramatically change. So I would expect that let's say in 50 years, you basically have it's not intensive care, but intensive monitoring beds throughout the hospital. And that if you do not need one of those beds, you will be at home and will perhaps even have remote monitoring. And we at the moment, patients are too many patients are stuck in hospital beds just to be in the hospital without any obvious benefit.
Yeah, that's a really good point, and certainly plays into that idea of how that cost is disseminated. So if you may have a large cost up front, but if you can move those patients out of the hospital, that certainly can reduce patient cost. And as you said, really redefine what the clinician is doing at the bedside. I had one last question here I wanted to get to, and it's kind of a big question, encompasses a lot of what you have spoken on already, but in your opinion, what is the main barrier in transitioning from spot checks to continuous monitoring?
I don't really know, because it's if you think about it, it's very logical. So I think almost every clinician theoretically agrees that patients should be continuously monitored, and I think the barriers are very pragmatical ones. First of all, those the systems generate a lot of alarms, and those alarms, as I said in the presentation, need to be handled in a clever way. So they need to be contextualized, individualized. We need to reduce the amount of artifacts, because too many alarms cause alarm fatigue, and people will simply not appropriately respond to the alarms. So I think this is an area where we really, really need to focus on, because just implementing the system, starting measuring, and not thinking about the alarm and response and treatment part of it will almost certainly result in failure, because people will not will not appreciate if they need to deal with many alarms. So good systems that are already available cause only very few alarms per day, because they really are able to identify those that are important. And as you know, change in medicine is something that happens very slowly. We are, as clinicians, we are very reluctant to change, and we need to remind ourselves that the way we monitor our patients today is basically the same than like 50 or 100 years ago. And this is something that needs to change. Almost everybody now has a smartwatch or any other device and counts their steps and measure their heart rate and whatever. And as soon as you enter a hospital, your monitoring basically goes down to zero. And this is something that we cannot accept. But we need to do our homework, and the main barriers are the let's say, boring or annoying things like dealing with alarms, implementing this into IT infrastructure, and many other small hurdles that in the end result in the current situation that those systems are available and used for research purposes, but hardly routinely implemented in hospital systems. But this is about to change, I hope, in the next years.
Thanks. That is a great summary of a very complex question. So certainly there are many barriers, but I think focusing, as you said, on those tangible pieces, those kind of less interesting pieces, maybe the IT piece and the alarm burden piece will be huge. So with that, our webcast is coming to a close. Thank you all for your time and attention.